Tell us your thoughts about any breakthroughs, anything that's really new in the last few months that you're inspired by.
The last few months? Oh gosh. Of course, been involved for so long is all relative. I mean, I first started looking at this area 3.5 years ago. You know, that was when I wrote the blog post about my medical record that ended up on the front page of the Boston Globe, which led to the frustrated expression that became the title of my first keynote ever, which was, "Gimme my damn data, because you guys can't be trusted," which now, by the way, is a rock song. If you can search for it. Some guys from Deloitte have a garage band, and they did it. And it's, I mean, who knew? Well, so that as part of all of that, see, we are engaged, we are in the middle of, in the early stages of something that is nothing less than a culture change, and I mean real culture change, in the sense of our shared beliefs about what's possible and our expectations about who is expected to do what and who is believed to be capable of what. And one of the big things here is we have this Society for Participatory Medicine that was formed in 2009, which has boomed to the point where we now have almost 400 members, right? And we define that as a movement where networked patients shift from being mere passengers to being responsible drivers of their care, or their health even, and providers welcome them. Now, to a lot of people who were trained to think only about the scientific method, it's hard to imagine that there could be any genuine medical value generated by people who haven't been to medical school. I give keynotes now about how that is a reality, and people who are in denial about it are going to be blindsided. This morning, Todd Park mentioned Hugo Campos, the ICD patient who wants the data stream coming out of his device. He's doing everything in his power to stay healthy, right, as opposed to being more effective in dealing with problems when they arise. A great example of this shift, and in research, I've started to work with PCORI's Patient Engagement Advisory Group. There's a real debate going on in there, because it's the normal thing is for highly trained researchers to think their best about what they can do for patients. And this is quite analogous to the Medicare, the CMS program, Partnership for Patients, which a couple months ago underwent something of a rebellion by, of all things, the patients. In the middle of a webcast, the famous Regina Holiday pretty much grabbed the microphone and said, "Can you hear the paternalism in this? We here are going to do things to take good care of you." And she right now is running a conference in Kansas City. I was there yesterday, Partnership with Patients. And some of the people from that webcast are there. Anyway, at street level, the people I bump into in my grocery store is the way I think of it. Nothing has changed about patients engaging with their data. But what has shifted is the conversations we have at conferences. The people who set policy no longer are saying, except a small minority, no longer are saying the patients have no right or that it makes no sense for patients to be involved with their data. What we need is better software to take this. Well, the classic example is Thomas Getz of Wired, who Todd also talked about this morning, who looked at the stupid, dumb dot matrix printer listing of his blood work and said, you know, this is what my financial reports looked like 20 years ago. Now financial analysts compete based on how pretty their graphing software is to make the information noticeable. And so suddenly the consumers who used to be disempowered from understanding that stuff can. And he took it to his design department and said, can you make this look like a 401k report? So, and they did. You can Google it. It's time to, he has a TED Talk, it's time to redesign medical data. So, we're in early days. Great things are around the corner, mark my word.
Thank you, Dave. It's always good to get your perspective, and so much in there that we can perhaps dig into if we have more time. Ted, here's one for you. What is Kaiser doing that's truly engaging with patients And what evidence do you have that it actually makes a difference?
Sure. I would say, what is Kaiser Permanente not doing? And I think what we're doing is actually showing that this kind of interaction is normal. We've always believed that patients and families should be involved in care, and now with technology, we're able to do it. And by the way, I'm now based at a facility we have in Washington, D.C. called the Center for Total Health on Capitol Hill. People are welcome to come see it. And so what we're doing now is actually we're able to tell the story based on 4 million people online with us times 10 years, so 40 million patient years of experience. And the numbers are staggering. So we have 17,000 physicians across the country who 100% of are emailing their patients, sending them lab test results, and available now via mobile device. So it is now possible to email your doctor from your Android, your iPhone, or any web-enabled mobile device as of January. So you think about the culture change that that has been for us, and it's actually quite normal. So we are on the same page with our members all the time. The advantage of being a nonprofit delivery system and health plan at the same time allows us to generate a lot of data that's very helpful. So we publish our results. There's a really nice study from 2010 that looked at all the patients in Southern California, about 500,000, who had diabetes or hypertension or both. And if you look at patients that did or did not send email to their doctor, even the same doctor during that time, significant improvements in glycemic control, hypertension control at both levels, the new level of 130/80 and the older level 140/90. Lipid control, it's basically P, if you're a researcher, P less than 0.0001 for all of them. So it's basically proving what we've all known, which is that empowered patients and families do better in health and healthcare.
Well, what you're really saying, I think, and we have data on this as well from our center, is that engaged people do better.
Yes.
And if it sounds silly, but if you're engaged enough to send your provider an email, and of course you're in a system which is so important that encourages that you'll do better. Simple, easily measurable, very powerful though. So Sue, from your perch at the ADA, I'm assuming it's never a dull moment. You must see amazing things come through the door. Everyone, I'm sure, wants to talk to you and share what they're doing to help move diabetes care forward. What would you say is the most innovative engagement strategy you've seen of late, and why?
Right. So just to step back for a minute and give a little bit of background, I think we've all heard of the 99.9% rule, which has nothing to do with the 47% rule, by the way. But we all know that people with diabetes spend perhaps 0.1% of their time, engaging with the healthcare system or in the outpatient clinic, and the other 99.9% of their time, they are responsible for making the choices, having the control, and reaping the consequences, either good or adverse, of choices that they make. I would say traditionally the ADA has been, at least my area of the ADA, which is over our medical guidelines, and we're very involved in professional education, that sort of thing. We spent a lot of time on the 0.1%. And for the 99.9%, I think we've traditionally thought of ourselves as providing information, and we all know that information is important, but it's necessary, but certainly not sufficient. So I would say, in terms of the ADA, I don't think we're a particularly innovative organization. We're kind of tried and true. But we are definitely trying to move more towards actually looking at outcomes of what we provide for people with diabetes or those who support people with diabetes. We're moving beyond just measuring things like how many people saw our information, how their knowledge increased, and actually trying to measure real outcomes, behavioral outcomes, self-efficacy, and that sort of thing. It's not really innovative. It's something that everybody should be doing. I think another thing is that there are some very innovative things out there, but unfortunately, I think as Todd said earlier, the future is here, but it's not widely distributed. So there are some very innovative things. There's some, I think the system redesigns around accountable care organization and patient-centered medical homes are very exciting, I think. But unfortunately, there's a lot of medical care that's going on, including a fellows clinic that I volunteer in, that it's really depressingly no different than a couple of decades ago when I was a fellow, other than that we don't write in paper charts anymore, we type into computers. So, there's a lot of great stuff out there, but I think we really need to tackle health system redesign and perhaps even more importantly, societal redesign, because we don't live in a society that makes it easy for people to make healthy choices.
Outstanding. So I'm going to open it up now. If you all are shy, I always have a couple in my back pocket, but let's bring the lights up a little bit and offer the microphone to these three wonderful, talented people who are in this every day. Please.
I'm from Southeast Texas and a multi-specialty medical group that's dominated by primary care. We're a medical home. There are two things. One is your point one is well taken, 1.1%. The most important number in healthcare today is 8,760. I know everybody knows what that is, so I won't tell you. But okay, I'll tell you. That's how many hours there in a year. If a patient's getting lots of health care, they're in a provider's presence 10 to 20 hours a year. That means 8,740 hours a year. Guess who's taking care of themselves? They are. The second thing I want to comment about, then get your response, is sharing data is one thing. Transparency is really another thing, because transparency not only deals with data, but it connects that data with a person, on both ends, both the person who is creating the data and the person who is receiving the data. In 2009, we decided to be transparent. We began publishing our providers' performance on over 300 quality metrics by provider name publicly. And on our website for our 2009, 10, 11, and then for the first 3 quarters of 2012, so far, that data is there. Our patients receive, at the time they're seen, the data that we collect at that point. It's done electronically, takes 2 seconds to do it, and they're given a document. Not only has their plan of care, their treatment plan, their goals and where they are in those goals, but also where they are on receiving the quality of care that these kind of healthcare GPS data points of what they ought to be receiving is, and with a note saying, if you've not received all this, then bring this back and next time you're there and ask the yellow belly, egg-sucking dog provider that you have. We don't say that. But to give you the care that you deserve. So we empower the patient, we're transparent with the patient, and it's significant how that has changed the behavior of providers and of patients. Have you had experience with, and your drive to have transparency and empower patients to where they actually know how their provider is performing and how the group of providers they're receiving care from are performing?
Who wants to take that one?
I would just say for the 8760, so in our system it is an 80, it's more than that, because remember they can access us whenever they want. So we've been doing this for 10 years, and so we don't limit ourselves to the physical space of the medical office or the hospital. So I think, when you get an email from your patient in China or Sweden and they don't know what's going on, you really feel glad that you're there for them and you have all their medical information accessible. So I think we should move away from that concept that it's the 0.1%. The other thing is that when people do interact with us anywhere, anytime, whether it's actually on the phone, in the medical office from the receptionist, from the specialist even, they are reminded about all their care gaps. And that is a combination of all our data systems coming together at the right place in the right time. Because if you know that 40% of the time a patient presents to a specialist, not to a primary care provider, and the specialist is not telling them about their preventive care, that's a missed opportunity.
Other comments from, other question? Yes.
Hi, I'm Amy Tendrich with Diabetes Mind, and my question's for Sue. Hi, Ted. My question's for Sue of the American Diabetes Association. I'm going to put you a little bit on the spot, but since this is a panel on patient perspectives, I just want to ask you, what is your view of what most patients want from the ADA, and are they getting it?
I think we know some of what people want from the ADA, but certainly not everything. And of course, as you know, we talk about patients or people with diabetes as if they're this homogeneous group. And of course they're not. And so, people have different types of diabetes, people are different ages. So it's hard to say that, people want X from the ADA. We do know that people with type 2 diabetes, for example, we implemented a program called Living with Type 2 Diabetes for people that were newly diagnosed. I think a lot of people had preconceived notions of what that program should look like. People, thought that people would want webinars and would want web-based information, and would want to get information at their church or their library or whatever. And we actually, asked a bunch of people that have been diagnosed with type 1 diabetes or type 2 diabetes, relatively recently in recent years. And it turns out they wanted kind of old-fashioned, I want something from my doctor. I don't want to get it from anybody else. And I want it on paper. I want to be able to take it home and read it over and over again. So I think, we have attempted to sort of find out what some types of patients want. In terms of type 1 patients, we're trying on our social networking to find out more about what people want. There are lots of complaints, and we want to try to find out what it is that we can do for example, for adults with type 1 diabetes. So do we know enough? Absolutely not. Do we need to know more? Absolutely. So anything that you can do to help us with that would be great.
Joe?
Yes.
Could I add a little something on that?
Please.
So this is not specific to diabetes, but it is specific to the general question of things being patient-driven. Jessie Grumman, who some of you may know from the Center for Advancing Health, a 4-time cancer survivor herself, very smart person. Her team last year published a patient engagement framework, 53 discrete behaviors they'd identified in 10 categories that everybody needs to do or have done for them at one time or another. But in our e-patient community in the society, we've started talking about adding an 11th level, which is designing and creating a care system that is more what patients want in the first place. And the good people at PCORI are facing some really interesting challenges now, because looking at patient-centered outcomes within the current research paradigm is a whole different thing from what do you do if what the patient community wants you to work on is not even on the research agenda. So this is the beginning, I mean, a cultural revolution. Keep your eyes open.
Next. Yep.
Hi, I'm Emily Jones from the Office of the National Coordinator for HIT. A question for Dave and anyone else on the panel.
Sorry, we can't hear you very well.
Oh, sorry, I'm Emily Jones from the Office of the National Coordinator for HIT, and a question for Dave and others on the panel. What would you like to see in meaningful use stage 3 or other policy levers that we can really use to help patients get more engaged?
Well, I'll be very simple, short, concise. Give me my damn data continuously, as Todd described, make it available as a continuous stream, make it easy for me to send it anywhere I want using the direct protocol and the open authorization, the OAuth thing, so it's easy to get at. We can talk more if you want to go into great depth. Essentially, nobody in the professional community has any idea what patients will be able to do. I don't know, was it you this morning that spoke about having the condition for 27 years and being frustrated that the research is about the mean people, so to speak, and just, there's a bunch of us out here who would love to, like Hugo Campos, take all the data we can get and do our own research on it without impacting the federal budget, not to mention if the government did want to help.
I would just add, not speaking about the specifics, but meaningful use is if the patients can use it. So
Yes.
for many, many years, I was helping to roll out an EHR, and the conversation kept being EHR for doctor, PHR for patients. So luckily, we've moved away from that. EHR for patients. It helps us perform better for them. And we are actually showing that patients that use our personal health record at kp.org are more likely to stay with their health care because of it. So I would say the outcome has to be that the patient is connected to that relationship wherever and whenever they want it.
a quick follow-up?
Sure.
It's one thing, in my case, my kidney cancer, there's a 50% chance, the best available data is that there's a 50% chance my cancer will recur. It turns out that's really bad data. It's just not really very relevant. It's one thing if a professional or the profession says, we really don't have good data, you know, to predict your outcome. It's a whole different thing if the profession says, well, this data isn't very good, but it's the best we've got, so obey it. Right? The great news is it gives us an opportunity to go back and rethink everything we learned in science.
Sue, quick comment?
Yeah, so this doesn't really have to do with meaningful use, but just talking about patient involvement in things like PCORI. I hope that is going to be meaningful, pardon the pun, because I have been on other panels where there has been a patient representative, and maybe they weren't as outspoken as Anna is, but they tend to sort of get ignored, and I think a lot of times a lot of groups want to say, check, yes, we have a patient rep, but then, you know, they're ignored. Yeah.
Go ahead.
Hi, my name is Linda Hermer. I have a question that's mainly for Sue and Dave, but I'd welcome any panelist comments. As far with worksite disease reduction, I really don't like the term worksite wellness. One of the things that's most effective in getting employees engaged in improving their health is delivering health risk assessment feedback along with continuing education provided by a trained professional. And I'm wondering, have any of your efforts involved bringing up the possibility of lap band surgery or going on, you know, weight reduction drugs, things with much greater risk, telling patients, look, your situation is so serious that this is, you know, some studies suggest that this would be a more effective approach. I'm wondering if you know, how well you feel it works to make the current situation sound grave enough that they might need a serious surgery with lifetime consequences. Not to be grim or negative, of course.
I mean, I can say if you look online, Kaiser Permanente Health Works. We're actually very engaged in what we call creating a culture of health. So it's everything from making the best choices easy, all the way through to complex medical care. And our heritage, by the way, is a physician who learned that he could actually do better business-wise if he went to the work site and prevented injuries. Mm-hmm. So that's the way to go. We exist on getting paid to keep people well. So if you look at that, we do everything from making sure every meeting is healthy to what's in our cafeterias, and we work with employers very closely to provide that environment.
Just a lot of studies in other countries suggest that lap band surgery is cost effective for employers. And I guess what I was really asking is just if patients are confronted with you know, the possibility that they might need that, is that moving enough that it helps catalyze behavioral change?
I don't know the data on like the best approach for population, but I know that anything like that is a serious decision, and so it all rolls back to us about prioritizing the relationship. And so what I see sometimes that's not effective is connecting people to websites rather than people. And I think, Joe, you were touching on this as well, is that everything we do from our mobile app to our web app, it's not just connecting to that, it's actually involving all of our care system, nurses, physicians, in that conversation, and that's always the best decision. Thanks.
We're out of time. Give our panelists a great round. Thanks, guys.